Thank you, Tina, and hello, everyone, and welcome. It is my privilege to introduce Dr. Michaela McIntyre. She is a physiatrist in the Brain and Spinal Cord program at the Toronto Rehab Institute with a clinical focus in acquired brain injury, stroke, and spasticity. She holds a full-time clinical academic appointment as a clinician teacher in the Department of Medicine at the University of Toronto, where she is an assistant professor. She completed her residency in physical medicine and rehabilitation at the University of Toronto. She also completed her master's degree in system leadership and innovation from the University of Toronto's Institute of Health Policy, Management, and Evaluation. She has a special interest in virtual care and education, including harnessing technology to improve access to specialist care in underserved communities. She has worked on distance education projects across Ontario, as well as in rural areas of Uganda and Nepal. I'm very pleased to invite and introduce Dr. McIntyre on her presentation of Pearls for Assessment and Management of Post-Stroke Shoulder Pain and Central Post-Stroke Pain. Dr. McIntyre?
Thanks so much, Eileen, and thank you, Tina, for having me today. It's such a pleasure to be with you all, and happy Doctors' Day to the doctors out there. And I know we've got a lot of different professions that are here today, so it's always a wonderful opportunity to get to be with each other and learn from one another. So if it is lunch where you are, then feel free to eat as we go through this. There will be a couple points where we can do some polls, and then I will save some time for questions and discussion at the end as well. So no real disclosures. I do volunteer with the charity Nepal Ability, doing some education work, but no conflict with what we're talking about today. And as mentioned, I work at UHN Toronto Rehab. So I just wanted to start with an acknowledgement of the traditional land. We acknowledge that the sacred land on which the University Health Network operates. For thousands of years, it's been the traditional territory of the Huron-Wendat, the Haudenosaunee, and most recently, Mississaugas of the Credit River. And today, the meeting place of Toronto is still home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work and learn on this territory. So here's what I hoped we could go through today. So we'll talk about a differential diagnosis and approach to post-stroke shoulder pain. Through that, we'll talk about some pearls for pharmacologic and non-pharmacologic treatments. And we'll also look at some guidelines for managing central post-stroke pain. And I do have a case that we can look at together, just to tie it all together. I do have a quick poll we can launch. So maybe we'll go to that just to get everyone kind of ready. So this is anonymous, but it's always kind of nice to just reflect and think about how familiar you are with the topic that you're about to invest your time in learning. So you can kind of vote not very, somewhat, or very. And once we get a few responses, then we'll just look at it and then go forward. Okay, so thanks so much, everyone, for weighing in. So we've got a good mix. So many of you are somewhat familiar, some are not very, and some are very familiar. So no matter what, we will have a chance to learn and welcome everybody's collective expertise and input as well throughout the presentation. So we're talking about pain today. So I always like to just stop and remember what the definition is. This is from International Association for the Study of Pain, and reminding ourselves that this is an unpleasant sensory and emotional experience. There could be actual or potential tissue damage. And we know that pain is actually adaptive. We need a pain system, but it can have adverse effects on our function, social and psychological well-being. And it's learned through life experiences in part, and the report of pain needs to be respected. But we know that the verbal description of pain is only one of several behaviors to express it. And one of you submitted a really thoughtful question when registering, which was kind of how do you actually assess for pain in our patients who have aphasia or maybe nonverbal. And when it comes to post-stroke pain, there's no kind of consensus one scale that you must use or need to use. But there are some papers that I just looked at and refreshed in response to your question. So a lot have studied the visual analog scale that has like faces, so that there's kind of numbers as well as faces you can use, or the numeric pain rating scale. So those are a couple that you could consider using. They're easy, they're at the bedside, and it's good to just keep in mind that there's other tools you can use besides simply asking. You can also always look at people's, facial expressions, nonverbal cues and things like that. So one of the reasons that Tina, Eileen, and I selected this topic was because it is so common. There's a variability in the prevalence, but some studies will report up to 73% of patients may get post-stroke shoulder pain. It can happen as early as the first couple weeks, but most commonly it's the first 2 to 3 months. And we know that it can have a significantly negative impact on people's progression through rehab. There are some risk factors that have been linked to a higher chance of shoulder pain. So those would be age over 70, poor arm motor function, underlying MSK pathology like supraspinatus, tendon injuries, biceps tendon effusion, adhesive capsulitis. One of you submitted a really great question, which was like, what's the natural history? Because I think in your clinical experience and mine, sometimes it seems like no matter what you do at the 2 to 3 month range, by 6 months, it seems to have improved. There are some studies, like there's one study that was done that found that in about 1/3 of people after stroke, they developed shoulder pain, but 87% up to them had it by 2 months within that. And by 6 months, the pain had resolved in 80% of patients. So I think that is kind of supportive of the point that it is common, it happens early. The natural history is favorable, but we also know that the first few months is often the time when we really want to have a push for progressing people through rehab as much as possible to take advantage of the window of neuroplasticity. There was a study that's on this slide here that showed a few factors that predicted development of shoulder pain. So that would be a positive NEAR test, which is an impingement test, pain during hand behind the neck maneuver, and a difference of more than 10 degrees of passive external rotation at the shoulder joint. So these are some of the things that you can consider in your assessment. Some of them may not be logistically that easy to do. So this is from the evidence-based review of stroke rehabilitation. And we are going to come back to this at the end just to kind of recap, but I love this diagram so much because it really just illustrates the complexity of post-stroke shoulder pain and all of the different factors that tends to be at play. And I think one thing to note is that in most cases that I see where someone's got really significant pain, there's probably more than one thing going on. And that's where it's really important to try to target from multiple angles. But we can think of it as kind of starting over here on the left. So you've got impaired motor control, you've got either some flaccidity, spasticity, loss of motor function, and that can lead to abnormalities in the scapulohumeral rhythm, as well as the potential for glenohumeral subluxation. That can then put you at higher risk of developing not only soft tissue lesions that we've got here, tendinopathies, bursitis, adhesive capsulitis, myofascial pain, but also alterations in the central nervous as well as the peripheral nervous system activity. So that's where we can have peripheral nerve entrapments, CRPS, central post-stroke pain, even neglect factors in as well. All of these things together takes us to multifactorial hemiplegic shoulder pain or post-stroke shoulder pain. I call it post-stroke because you don't have to be totally hemiplegic to have it, but as we know, that is one of the factors that's linked to having higher risk. Okay, so initially when I was making this presentation, I felt like it was a little all over the place because as we've just seen, there's so many different factors, but we're going to talk about a lot of these causes just in terms of some little practice pearls, tips, and tricks. So these slides will also be available to you after if you want to refer to them later. In terms of assessment of post-stroke shoulder pain, this is from Canadian Stroke Best Practices, their suggestions. So you do want to take a comprehensive approach. It's important to really look at tone, active movement, as well as the passive range of motion. That would give you a sense of the length of soft tissues. You do really want to look at alignment of the joints, not only just in one position, but I would suggest with functional tasks too. Often when if someone's in inpatient rehab and they're having a lot of pain, I won't only do my bedside assessment while they're in their bed, but I'll always want to try to join a therapy session to see how are they positioning when they're trying to transfer in their wheelchair and so on. You do want to remember to do not only a really good neurologic exam, but also an orthopedic or MSK exam to look for all those MSK contributors. And then also to really, as best you can, assess the levels of pain and how does that impact not only their physical, but emotional health. I would say that when someone's got untreated mood or mental health symptoms, then that does make it a lot more difficult to get their pain holistically under control. Okay, so as I mentioned, we'll go through a few little tips and tricks for some of these causes. So shoulder subluxation is something that I see very commonly in patients who've had loss of motor control after stroke. So this is showing that even at the best of times, as we know, our shoulder joint is in place with our rotator cuff and ligaments that are prone to instability and injury. But once you've had alteration in the motor control, especially of your supraspinatus muscle, it does cause this subluxation. You can see the downward translation of the humeral head that's now impacting on the glenoid fossa. So So what you might see clinically is actually a palpable a gap between the acromion and the humeral head. You can also try, so you want to look at rest and with gravity, and then you also want to try to apply a bit of a downward pull and sort of see if you can actually increase it even more. Some of the classic teachings will tell you that subluxation is not a painful condition, but in my experience, it does seem to cause a lot of pain. And the way that I'll often see that is my patients will tell me that in certain kind of gravity forward positions, they do have a lot of pain. And then when you actually kind of clinically can try to kind of relocate the shoulder back to reduce that gap, they'll say, okay, now my pain is gone. So that to me is often a sign that the subluxation is probably playing at least part of the role. So, they say that an ounce of prevention is worth a pound of cure. So it is important to try our best to prevent subluxation if possible, or prevent contributing to it. So we really want to try to protect and support the arm during rest and functional mobility. So it's recommended to avoid overhead pulleys and also passive range beyond 90 degrees of flexion and abduction. So these are good points for refresher courses for those of us who do transfers and moving of patients, and to also ensure adequate supports in wheelchairs, the height of the armrest, use of a hemi tray or arm trough when possible. One of you had a great question about slings. So I do have a lot of patients that when I try to take their sling away, they're not happy about it. It does give people that kind of sense of protection and comfort, but we know that slings do have a lot of negative potential as well. They can discourage arm use, they can contribute to contracture formation, decrease body image. So we do want to discourage them outside of the flaccid stage. But for patients who do have a flaccid arm, when they're getting upright and transferring and mobilizing, then you do want to use some kind of a sling or joint protection. If patients have a flaccid arm, then you can also consider electrical stimulation. There's also some evidence for strapping or taping to reduce pain in the setting of subluxation. Okay, so I am a spasticity practitioner, so spasticity is something that's near and dear to my heart. It's another condition where in the classic teachings and textbooks, they'll say that spasticity itself should not cause pain. And, if we're trying to get coverage for toxin, they'll say, well, pain is not an indication. But, one of the providers who taught me said, if you clench your fist for 5 minutes as hard as you can, then, you're most likely going to develop some discomfort. And I do think that in my experience, patients who have a lot of spasticity will contribute to pain and discomfort, even indirectly through the different anatomical positions that then start to predominate. So when you're thinking about spasticity from a shoulder perspective causing pain, pectoralis major and subscapularis are probably the most commonly responsible muscles that you want to assess for. So that would be when you're assessing passive external rotation and abduction. And you want to remember that spasticity is a velocity dependent assessment. So that's one way that it can help you to distinguish between something that's an adhesive capsulitis as well as something that's from spasticity. Another pearl that I would say is that it's pretty uncommon for me to see only spasticity of the significant spasticity proximally, but not distally. So, if you're suspecting there's a lot of spasticity around the shoulder, then that's the problem. Then assess the rest of the limb, because if you find spasticity there too, then it's more likely to be the culprit. Whereas if it's really only there and the rest of the limb has reduced tone, then you might be more suspicious that it's adhesive capsulitis. In terms of treatment, so there have been reviews of randomized controlled trials that showed that positioning and stretching was not really helpful. That could just be that maybe the time was not enough, like maybe it needs to be longer and it's just not technically that feasible. In my practice, we do a lot of chemodenervation with botulinum toxin, so that's always an option if it's available. There's a lot of oral medications for spasticity that you can use as well if in your center botulinum toxin is not available. So I did kind of just touch on this as well. So keep in mind adhesive capsulitis. So you see a decrease in passive as well as active range of motion in a capsular pattern. So you lose your external rotation before your abduction, before your flexion. Studies show this is a really common problem in stroke patients who've had hemiplegia. And like I said, it does often go with spasticity. So you might be actually treating two things at the same time. So in terms of if you feel that this is present, then intra-articular corticosteroid injection is often very helpful. You can, if you have access to interventional colleagues, then they can also add a hydrodilatation to try to give the capsule a stretch, and then in combination with range of motion exercises and pain management. Okay, so complex regional pain syndrome. So we'll spend a little more time here just because this is, I think, a condition that it's really great to have in your mind when you're seeing patients who have significant pain, especially if it involves the shoulder, but other regions of the arm as well, because it is something that if you catch it early, it is really quite treatable and can make a big difference for your patients. So CRPS has a lot of different names. So it's known as, you've probably seen it known as reflex sympathetic dystrophy, shoulder hand syndrome, Sudak atrophy. So this is a condition that's characterized by sympathetic maintained pain and related sensory changes, abnormal blood flow, motor and trophic changes that can affect, in some studies, up to 48% of hemiplegic stroke patients. So it's actually more common than I think we previously thought. There's two types. So the type we would usually see after stroke would be type 1. That was formerly known as reflex sympathetic dystrophy. That is something that would develop without known peripheral nerve damage in comparison to type 2. That was formerly called causalgia, which resulted from a known peripheral nerve injury. So, why this happens, there's different theories out there. It's thought that with time that the sympathetic fibers can develop the capacity to activate nociceptive fibers. There's other thoughts, could it be due to disruption of the fluid balance between intra and extracellular compartments? As you've seen, a lot of our patients develop edema when they have decreased motor control. There's also thoughts that could be from increased capillary blood pressure and increased capillary permeability due to inflammation. That could be triggered by rough handling of the limb. So a lot of different theories and hard to know exactly why, but we do see that there is a link. Okay, so stages of CRPS. So in the acute phase, what you might see is kind of burning pain, edema. You might see vasomotor changes. I'm going to show you a clinical criteria in just a moment. In the 3 to 6 month, that's more subacute. That's more of a dystrophic phase. So you might start to see atrophy, cold insensitivity, and mottled skin. And then in the atrophic or more chronic phase, then pain may actually decrease, but you may see that now the limb looks pale, cyanotic. There could be sustained weakness and contractures. So this is why I say you do want to try to prevent CRPS from getting into the dystrophic and atrophic if you can. It's more treatable if you could catch it in the early first few months. So this is hopefully not too small on your screen. This is the Budapest criteria for CRPS. And so if you're suspicious that this might be occurring, then you can always pull this up in your clinic just to kind of have a little bit of a refresher, and you can try to assess for it. So first and foremost, you want to keep this in mind. So having continuous pain that's disproportionate to the inciting event. And then you want to have at least one symptom reported and one sign in these 4 categories. So sensory, vasomotor, pseudomotor edema, and motor trophic. So the person could be reporting, like just a lot of pain, sensitivity, temperature and color changes, sweating changes, decreased range of motion, weakness, changes to hair, skin, and nails. And then those are some of the things that you'll be looking for as well. So you can do, your usual neurologic exam, really do a good sensory examination as well, and look for allodynia, so increased pain to non-painful stimuli, or hyperalgesia to increase pain to pinprick. You want to, if you've got a temperature probe in your clinic, you can actually measure the temperature side to side. And then you really want to look at skin color changes, sweating, and then these motor things as well. And then it says no other diagnosis that better explains the signs and symptoms. So where I think this can be a little tricky is because if you've got a stroke patient, as we know, then they're going to usually have weakness, sensory changes, some edema. So it's not that easy to tease it out. I would say in my experience, one of the pearls is just if the pain, it just all of a sudden accelerates so much, you feel an increased kind of warmth and tenderness, and the pain is just kind of unrelenting and severe. Then it might be worth actually trying treatment for CRPS. You can do another diagnostic. You can do a diagnostic test with something called a bone scan. It's a triple phase test, so there's 3 phases, and then there's characteristic findings. But if you're really suspicious of CRPS and you feel they meet the clinical criteria and it's not too risky to just treat them, that might be the way to go, just in the interest of not kind of delaying their treatment further. So now, what is that treatment that I'm speaking of? So from Canadian stroke best practices, the recommendation is to use oral corticosteroids. So that would be like prednisone, starting 30 to 50 milligrams for 3 to 5 days, and then taper over the subsequent 1 to 2 weeks. I have followed this protocol, and I've had a lot of good success when this has kind of developed very acutely. The challenge is just making sure that there's not significant contraindications to corticosteroids for the patients that you're working with. Other treatments that you can use. So there are other medications that you can use. So those would be anti-inflammatories, tricyclic antidepressants, bisphosphonates, anticonvulsants, even calcitonin intramuscular has been studied. You can also use modalities, so TENS, so that's transcutaneous electrical nerve stimulation, contrast baths, or ultrasound. There is level 1A evidence for trying mirror therapy, and then injections as well. If you have access to interventional colleagues, either intra-articular or nerve blocks can be tried as well. So now I mentioned type 2 CRPS is from nerve injuries, but keep in mind that our stroke patients can also get brachial plexus or other peripheral nerve injuries as well. And so you do want to think about this when you're assessing. It can, again, be hard to tease out just because you've already got weakness in a kind of a diffuse pattern. But keep in mind that if you're seeing kind of an atypical functional return, then it might be something to investigate further. This could happen from traction neuropathy, so kind of pulling injuries to the limb as well. And as we know, if you've got a patient who's got significant neglect, then often their arm, you might see them with their arm hanging down, or there might be a sustained abnormal position in bed, so they could have a compressive injury from that. So some things that you might see is, if you see a finger extensor contracture, or very delayed onset of spasticity in certain muscles, then that might be cues as well that you might want to get electrodiagnostic studies to confirm your diagnosis and also help with prognostication. So treatment for nerve injury, so you really want to prevent further injury, so proper positioning, preventing compressive points. There's our usual neuropathic pain agents, so that would be our gabapentins, pregabalins, SNRIs, TCAs, and then you can consider, if it's a severe injury where the prognosis is poor, on electrodiagnostic studies, even a surgical intervention. We know that it could also take several months for nerve reinnervation too. So now I won't touch on these in detail just because I'm watching the clock, and I do want to make sure that we have enough time to go through our case and also answer any questions that anyone has. But just keep in mind that, as we know, rotator cuff disorders are so common. So those can definitely be concurrent and can be exacerbated when someone's now got alteration in the motor control around the shoulder. And as well, biceps tendinitis or tendinosis too. So really you want to look for those because there are kind of interventions that you can do for those when they're present. Heterotopic ossification. So we can talk about this more at the end if people have more questions. I guess what I would just say is that it's really infrequent in stroke, but it could theoretically occur. So that's something that you would want to think about. If you've kind of ruled out everything else, you could get an ALP, you can get a bone scan. If you want to look for that further, it can show up on x-rays. It just takes some time too. And then keep in mind dependent edema too. So we know that when someone's got a lot of edema, that will cause the limb to be more uncomfortable. That can also contribute to kind of increased heaviness of the limb. That could be contributing to subluxation. So all of our usual edema managements too. So elevation of the limb, retrograde massage, wrapping, things like that. Okay, so I talked about a lot of management as we went through some cases, but just to kind of recap and round out, some of the general recommendations from Canadian stroke best practices are shown on the slide. So we do, and this is where it's, one of the reasons that I do love this topic is because it is such a collaboration between all of us, all of our colleagues in nursing, allied health, MD. We all work together in different ways to target this problem. So it's really important to have gentle stretching, mobilization techniques, progressively increasing external rotation and abduction when there's limits in range of motion, with just caution to not avoid the extremes or overhead pulleys like we talked about. Taping of the affected shoulder, that's something that some of my colleagues will try for patients, and some of them really like it. The biggest thing I find is just when they're actually leaving rehab, they're saying, oh, I'm not sure who's going to be able to do this for me, and that is a limit. There are kind of stabilization braces that we've sometimes ordered and tried for patients, but I find they can be a little bit cumbersome, a little bit tricky to use. Don't forget you can use simple analgesics like ibuprofen, acetaminophen, or even sometimes narcotics for resistant cases on an individual case basis. We've talked about injections of botulinum toxin into the subscapularis and pectoralis, and then subacromial or humeral corticosteroid injections can be really helpful as well if there's any bursitis or adhesive capsulitis. Okay, so just want to shift gears here to talk a little bit about central post-stroke pain before we get to our case. So this is kind of under the umbrella of central neuropathic pain, which we know is basically any pain that arises as a direct consequence of a lesion that affects the somatosensory tract system. So you may have heard of the thalamic syndrome, Le syndrome thalamique from Desjardins and Rossi. So this concept was introduced a long time ago and was kind of thought to be around the thalamus predominant, given that it's our sensory center. But we know now that these lesions do not necessarily need to involve the thalamus. We also know that they can be from ischemic or hemorrhagic causes. The pathology, we think it's this dual combination of kind of nerve like denervation or deafferentation, and then subsequent development of neuronal hyperexcitability with some of the loss of the descending inhibitory systems. So in terms of actually diagnosing this, so you need to have pain in a plausible distribution, a history of a relevant lesion, some kind of negative or positive sensory signs, and then confirmation of the lesion by a diagnostic test. So that means just like seeing that there was a true central nervous system lesion using imaging or other testing. We know that the pain can be spontaneous or it could be triggered by certain movements or other things. And the other thing to note is that it doesn't have to be the whole one side to be considered central pain. It can actually be a smaller area. So some of the studies say that this is not that common, only maybe 2, but up to 8% of patients. But some other authors would argue that this condition does not get the attention it deserves, and it's actually more common than we think. So some risk factors that might trigger your mind that this is going to possibly occur would be increased stroke severity, female sex, alcohol intake, previous history of depression, hyperlipidemia, diabetes, or peripheral vascular disease. So now in terms of management of central post-stroke pain, so this is from Canadian stroke best practices. So the first line treatment is an anticonvulsant such as gabapentin or pregabalin. So I would say when I have someone we're suspecting of this, if they can take gabapentin or pregabalin, then we'll start that, and we'll really try to up titrate that to a healthy dose before moving on to adding another agent. So I would say you would kind of want to get it up to about 600 3 times a day or more before you could say that it's really not working. We know that's gabapentin, for example. We know that could be used even up to 900 3 times a day if the person can tolerate it. The other good thing about these is that you don't have to worry about lowering the seizure threshold because they're anticonvulsants already. Second line treatments would be our tricyclic antidepressants and SNRIs. And resistant cases, you could consider opioids and tramadol. But there is this disclaimer that there is a risk of physical dependency. So you do just want to use risk stratification tools, but you do want to try to treat your patient's pain because we know if it's present, it can have a really negative impact on the progression. Okay, so I know that was a bit of a whirlwind. I hope it wasn't too fast, but I thought we could next just work through a case that kind of ties all of this together. So this is a real case. I've actually seen this person very recently. I just changed some of the identifying details just for their confidentiality. So they have a history of a right thalamic intraparenchymal hemorrhagic stroke. In the context of having a high INR, they have a mechanical heart valve, so they're on warfarin. So they were coming in to see me at about 4.5 months after stroke for follow-up after completing their inpatient rehab. And as I prepared, I noted that unfortunately they've actually been to the emergency room 3 times since leaving my center with significant pain in the left shoulder and hand, which is their main concern for today. So my examination, so this is some things that I checked. So in terms of looking at the shoulder, there was a limit in active flexion and abduction, which was partly from weakness. With external rotation beyond about 30 to 40 degrees, there was pain that affected the anterior and lateral shoulder. There was tenderness, quite significant tenderness when I palpated the bicipital groove, approximately. And then a lot of my special tests were positive. So the Speeds test for biceps, cross-arm adduction test, MT-CAN test for supraspinatus, as well as passive impingement tests like Mears and Hawkins-Kennedy. And then turning attention to the hand and wrist. So there was notable swelling compared to the right. There was erythema and color change. There was increased temperature compared to the right. So MCP squeeze, so kind of squeezing here, was strongly positive. There was a decrease in light touch and pinprick compared to the other side. And there was weakness and coordination deficits, but it was hard to tell in the context of their pain. Okay, so we've got an anonymous poll, so we'll just launch this. And hopefully it's set up so that you can select more than one thing. Yep, okay, perfect, thanks so much. So just go ahead and check off what investigations would you like at this point in time. So we'll just give a few more seconds for anyone else who hasn't weighed in to weigh in, and then we'll take a look together. So Eileen and Tina, yeah, feel free to share the results. So I'm not sure if you all can see them. I hope you can. But yeah, it looks like we would like, basically, some of us would like all of these investigations. So yeah, x-rays of the hand and wrist and shoulder, MSK ultrasounds of the same areas, electrodiagnostic studies, venous Doppler, and a triple phase bone scan. So I know, I get why we kind of thought, can we do all of this? Because this is a pretty complex case. It's clearly significant enough that the person has presented to emergency department. They're not doing well. And we need to try to get to the bottom of this. So I don't have everything that we wanted, but a lot had actually been done because it had been 3 visits to the emergency room. So there was a Doppler ultrasound, so DVT was ruled out. X-ray of the shoulder we did not have, but we did have X-ray of the hand and wrist. So there was just mild degenerative changes within the radiocarpal joint. We had electrodiagnostics that had been done actually. So there was mild carpal tunnel, but it was bilateral, so it was not really felt to be contributory to the presentation. And as we know, like compressive median neuropathy at the wrist is something that we see a lot, even incidentally, when people aren't having symptoms from that. And then there was an ultrasound of the left shoulder that had a lot of findings. So moderate biceps tenosynovitis, focal subdeltoid bursitis. There was a low-grade tear of supraspinatus and calcific tendinosis of subscapularis. In terms of management so far, so they were started on gabapentin, and it had been up titrated to 300 milligrams 3 times daily. But unfortunately, they didn't really notice any significant improvements as of yet. Okay, so whole time. So now we'll just try to pick one. So what would you say at this point would be your leading diagnosis? And keep in mind, it's anonymous, there's no pressure. And I'll tell you, there may not be only one right answer, but just kind of want to hear from our group what we're kind of thinking at this point. We'll just give you a few more seconds and then we can take a look at our results together. Okay, so thanks so much everyone for weighing in. So over half have gone with CRPS. And then we still got, to a smaller extent, but still, 16% votes for post-stroke pain, 14% for adhesive capsulitis, 11% for biceps tendinitis, and 8% for subacromial bursitis. So I think everyone is on the right track here, because I think why I wanted to share this case, even though it was a case that I saw really quite recently, so I don't have the full resolution yet, was because I think it really illustrates what we kind of talked about today, that this can be a really disabling, these can be really disabling conditions. They can overlap with each other and be hard to tease out. And they do require kind of a multimodal and multidisciplinary approach. So what I thought there was a lot going on, but CRPS in my mind did kind of stick out. I did feel that they met that Budapest criteria that we looked at together. And in my experience, like CRPS, it's just the history, it was just so suggestive of just such kind of unrelenting pain, like recurrent emerge, like started on gabapentin, but unfortunately still like it's not really doing anything yet. Not that it's at kind of the full dose yet, but it's still at a therapeutic starting dose now with 300 3 times a day. So the challenge here was that, as I mentioned, that sometimes prednisone can be risky for our patients. So this was a kind of a coordinated effort between the person's primary care provider and their cardiologist. So I reached out to the primary care provider and we reached out to the cardiologist together just to try to get some kind of just approval and awareness that we want to try a short course of prednisone. with concurrent pantoprazole because they do have a bleeding risk with warfarin, and it was a risk-benefit discussion as well. And aside from that, continuing to increase gabapentin because we know that this is one of our first-line choices for central pain, which I think could be present as well. And that, the 300 3 times a day is still kind of a low-ish dose. So the person was tolerating it, so try to keep going up. Another thing had been that they were still waiting to start outpatient therapy. So they weren't really kind of moving or using their Limitol. And so as we know, medications are not the only treatment for these kind of conditions. We do want to mobilize, we do want to desensitize, we do want to try modalities, So myself and their inpatient social worker have been in coordination with trying to expedite starting up their outpatient rehab program. And then also referred to my interventional colleagues to consider especially if they end up not being a candidate for oral oral prednisone, then can we try at least something to target the MSK pathology around the shoulder, potentially nerve blocks. So, more to come. I mean, if by any chance we have a follow-up session, then I can report back. But just to kind of bring us back as a summary before we get into questions and discussion. So just remember that post-stroke shoulder pain is complex. We know it kind of starts with this change in muscle tone and motor control. That puts people at risk of having soft tissue lesions that could have also been present to some degree before and then become a lot more problematic. And especially adhesive capsulitis, that is so common, as well as an alteration in central nervous system activity. That can cause things like central post-stroke pain that we've talked about today, peripheral nerve entrapments, CRPS, and all of that together leads to our pain syndrome. I always like to try to leave with a few kind of take-home points to reflect the value of your time being here for an hour over lunch. So just to kind of remind ourselves that shoulder pain can be due to, hemiplegia itself, an injury or acquired orthopedic conditions, any compromised joint and soft tissue integrity, as well as spasticity, which, as we've talked about from my clinical experience, spasticity and subluxation can put people at risk of having pain. So keep those in mind. And then always look for the MSK considerations in your assessments. So look for adhesive capsulitis, tendinitis, and rotator cuff pathology, especially. So always have CRPS in the back of your mind. So don't hesitate to just pull up the Budapest criteria. If it's been a little while, I do that in my clinic all the time. And just remember that, the earlier you can catch it, the better. So if you're, someone in allied health and you're working on non-pharmacologic techniques, it could be still a good reminder to people to really follow up with their medical team to look at some of the medical treatments as well. And then for central post-stroke pain, remember, it doesn't have to be one whole side. It can be a regional area, and it is a clinical diagnosis. And the first line choices are gabapentin and pregabalin. So just bringing us back to our objectives. So hopefully now you've got a differential diagnosis and approach for some common causes of post-stroke shoulder pain. Hopefully you've got a sense of some of I know I focus on pharmacologic, that's kind of where I live and work, but some of the pharmacologic and non-pharmacologic evidence-based treatments and the diagnosing and guidelines for managing central post-stroke pain. As I mentioned, a lot of my resources were from these two. So the evidence-based review, stroke rehabilitation. I love this resource. It's so in-depth, it's so comprehensive. And there's a great chapter on hemiplegic shoulder pain and CRPS, complex regional pain. And then Stroke Best Practices as well has two great sections. These are wonderful living guidelines. So there's also a section on management of shoulder pain, CRPS, and management of central pain. So with that, I shall turn it over to Tina and Eileen for the questions portion of this. And I guess we can leave the evaluation slide up as well.
Yes, thank you, Dr. McIntyre. That was awesome. And we have some time. You've left some time for questions, so please feel free to use either the chat or the Q&A. If you would prefer, you can raise your hand and then we can unmute and ask your question verbally if that is easier. Okay, so I don't know if anybody has anything Okay, so we've got a first question. What is mirror therapy?
Oh, yes, thank you. And I know we have a lot of therapists on online. So if any of you are, I know it's a little hard to chime in webinar form, but if any of you want to, please do, because I don't actually administer mirror therapy, but I do observe my therapy colleagues doing it quite frequently. So this is where you might have heard of it a lot. Like the first place I encountered it was actually in the amputee world, where it was used as a treatment for phantom limb. So it's actually kind of using a mirror to kind of mirror the unaffected side. And I do see my colleagues using mirror therapy a lot in stroke for neglect and other conditions. So I'm not sure if anyone wants to kind of chime in with more specifics, but if you've got colleagues that are providing rehab, you can certainly ask them if they are able to try mirror therapy for these conditions.
Okay, so certainly if there is someone that is administering it and they can raise their hand and provide more information, that's fine. Dennis Sawyer, I'm going to allow you to talk. You've got your hand up.
Hi, Tina. It's Julie Horrocks asking this
Oh,
question.
okay.
Hi.
Hi, Julie.
Hi. We are considering taping one of our patients now. I've done it before with the Hypafix and the Leuco tape, both to get external rotation of the humeral head as well as to reduce some of the subluxation. But we do have a fellow who has sensitivity to taping, so we'll have to do the pre-test strip for sure. But somebody was talking about using the K-tape. Which is your preference? And I think what we'll need to do is not only assist with better positioning, but also turn off the biceps,
Mm-hmm.
the pecs, the pectoral out. Yeah, the pec muscles. Yeah. So what is your experience with that? What would you advise?
Yeah, so love the question. And again, anyone who actually does the taping, please feel free to weigh in. But I will say that some of the therapists at our center will use K-tape, and it can work well. So I think definitely if you want to try that, and I do feel like your thought of kind of trying to kind of position and the way that you suggested sounds really good. Oh yeah, I wasn't sure if someone else was weighing in. So someone's weighing in the chat about mirror therapy, but if anyone else wants to weigh in about their experiences with using K-tape, we would love it. I love how we can co-learn together in these kind of sessions. But I see Alicia, thank you, has put a great link from EBRSR to a summary of mirror therapy. So that's great. I'll check that out myself too.
Okay, well, we've got a few more minutes. Okay, Eileen.
Thanks, Tina, and thank you, Dr. McIntyre. I just wanted to focus a little bit on heterotopic ossification. I know you mentioned it, but we didn't have a lot of time. But I'm just wondering, I know you said it's infrequent, it's rare, but do you see it? And what might be some pearls of management that you could quickly share with us?
Yeah, thanks so much, Eileen, for the question. So exactly, I did totally gloss over this because I work in stroke rehab, but I also do brain injury rehab. And so when I'm working, especially with traumatic brain injury patients, heterotopic ossification is actually more common than I think I realized, like from the theory to actually now being in practice. So it is something that it's theoretically possible in stroke, but I've seen it quite a bit in traumatic brain injury. And so if you're suspicious of that, what you might see, so in traumatic brain injury, it's often around the elbow. So you might see and kind of an atypical swelling, and you might actually be able to feel that there's some firmness there. So ways that you could actually look for it. So like I said, x-rays would show it, but it takes a while for the mineralization, so that extra bone deposition outside of bony tissue to show up. So you don't really want to wait till it's on an x-ray ideally. So what you can do is get an ALP, so a serum ALP level, and you can track that because, that will peak as the heterotopic ossification peaks. But yeah, a bone scan is a good way that you could actually detect that as well. And when you find it or you're very clinically suspicious, then the treatment is a bisphosphonate. So some of you who've looked at the guidelines for it will probably see a tidronate listed, but unfortunately, at least for us in Canada, it's not really available. So while there's no exact consensus, actually my brain injury colleagues and I were just chatting yesterday, and the best consensus that we could come up with is to use alendronate. So if you're going to use, then you would treat with alendronate like you would for other like osteoporosis, and then you want to follow the ALP and treat until at least it resolves, which can be up to 12 to 18 months. And when patients have very severe HO, then you might consider a surgical referral, but you want to wait until that 12 to 18 months when the bone deposition has finished.
Thank you. Tina, I was also noticing in the Q&A, we had a
Yep.
question. I'll go ahead then. The question
sure.
is, how can we progress the shoulder range of motion training for a stroke patient that has post-stroke shoulder pain above the shoulder level if using pulleys or above the shoulder level exercises should not be used?
I see. Yeah. So, yeah, I know. I think it's, you know what, I guess at least in the medical world, we are always saying, and I think it's probably the same for everyone, like first do no harm. So I think I would say like, I would kind of stick to the kind of range of motion recommendations, at least until you feel like you can progress more. It's not to say that you can never go above those kind of 90-degree flexion abduction. It says that, as long as like you're kind of very well supporting the scapula and supporting the limb, then you can. But if you're saying above the shoulder level, like, are you meaning where you're trying to target like neck pain? Because in that case, then you could also try to really examine the myofascial tissues and see if potentially, intervening on those could help. So that could be, gentle massage, trigger point release, heat, topical therapy, things like that.
Thank you. Hopefully that suffices. It was an anonymous question, so we'll keep an eye on it and see if there's anything further.
Okay. There's also a question in the chat. What about techniques like intra-tissue percutaneous electrolysis or neuromodulation for pain management?
Thanks, Alejandra, and hello to you. Yes, so there is some evidence for these modalities that you've listed that can certainly be tried as adjuncts. So we know, especially what I presented today was more about functional electrical stimulation, but certainly sometimes people will try acupuncture, electroacupuncture. We saw that TENS is something that has some evidence as well. And yeah, neuromodulation, biofeedback, these are definitely adjunct pain management strategies in general that can be considered. A lot of times it's really just access for patients, I find. So sometimes finances might be a barrier, and you're often trying to kind of decide where to kind of put people's precious time and resources. So if someone's going to go for something like this, then usually I'll try to tell them to be really explicit with kind of setting their goals, monitoring their pain levels, and kind of having a defined trial time of X number of weeks, and then reevaluate whether they feel like it's really helping and worth continuing or worth maybe trying something different. Like always, if anyone wants to chime in with their experiences, please do, because I have a lot to learn from you all as well, but that's kind of what I would say.
I think it's great reach we're having. Alejandro, I believe, is joining us from Puerto Montt in Chile. So what a great question coming from an international colleague.
Wow.
Yes.
Amazing.
Yeah, so just wondering, Julie, if your hand is still up from previous or if you have a new question. Oh, I guess not. Okay, so they've lowered their hand. Okay, so there's still a couple of minutes if anyone does want to type in a question, whether in the chat or the Q&A or raise their hand. But if not, I do want to thank Dr. McIntyre again very much for this incredibly important topic. We had lots and lots of interest, as you can see, from outside of our region and our province and even throughout Canada and internationally. So there is the feedback. We would love to provide some feedback to Dr. McIntyre using the QR code or the link in the chat. And also, as you log off, there is a link that you can get that way. Want everyone to know that tomorrow there will be an email coming from Zoom that has a link to the recording and to Dr. McIntyre's presentation slides. So there's lots of thank yous in the chat for the great talk and for addressing the question and from participating, for everyone's being able to participate in this. Okay. So
Thanks so much, everyone. Thank you for having me, and I'm wishing you all a great rest of your day.